in this talk. We are doing this health and well-being talks for some time, and this is in the part of the series of our health and well-being talk for the community. We will be asking the questions at the end of the presentation. The housekeeping is that initially we will do the presentation. We will ask all of our 4 speakers to give their understanding and insight about the vaccine and the COVID-19 itself, and then followed by the question and answer sessions. To make it smooth running, we suggested that you can put your questions on the chat box in the Zoom, and this way we will be able to answer your questions, and we put your questions to the panel. I'll briefly describe about Meem Foundation. So one of the core programs is health and well-being, and we are running the regular interactive sessions on the range of health issues. One of the themes was in March before the lockdown. Dr. Amar Hanan, who is our guest speaker again today, he gave a very good informative talk for the community. This was from the feedback from the community, so we have arranged this COVID vaccine talk because we are coming up with a range of questions about this vaccine. And just to inform our community about this basic facts about the vaccine and the COVID-19 itself, so we arranged this talk. We are doing the health and well-being sessions for BME women as well, healthy lifestyle with walking groups for men and women. We also arranged mental health clinics for one-to-one consultation, and also the elderly services for senior brothers and sisters. And we are actively involved in the community for COVID-19 relief work. But we also do a range of other core activities in youth development plan for the career guidance. And all our activities are the evidence-based, what is the community need, and feedback from the community along with our other religious programs. Although our talk is mainly for the COVID vaccine, but COVID-19 protective measures, we still emphasize, and I think this message will be repeated by all the guest speakers as well, that the protective measures still continue and hold, and washing your hands, wearing the face mask, and social distancing. I'll just put the picture that we have a snow here, and even the snowman has to wear the mask. As you could see, my daughter made this one. So just to share that, obviously the important thing is the protective measures, so that we will continue on that theme. So I will welcome our first guest speaker, Mr. Muhammad Salman Rashid. He's a consultant in acute and internal medicine at Barnsley District General Hospital, and he will update an insight from the first line as a medic dealing with corona patients. So I will welcome Dr. Salman Rashid, and he will also co-hosting with me, and he will be moderating the questions as well. So I will hand over to Salman.
Thank you, Dr. Tariq. And thank you everyone coming to the talk. My name is Dr. Salman Rashid. I'm one of the consultant acute and internal medicine, Barnsley District Hospital. I've been involved in COVID-related cases and their treatment management during the whole pandemic. So I will go to just a quick update about what's been happening, what's the quick treatment options. Definitely we're not touching about all the management plans because this is not part of our topics today. So, and I will not go through too much about vaccination because the vaccination part will be covered by my other colleague. You all know this is a coronavirus. We know up till now that it is RNA virus, positive strand. In December 2019, the first human case we discovered, reported by Wuhan, China, and in 30th of January 2020, the WHO declared it's the public health emergency of international concern. Up till now, today, as per date, we know that about 80 million cases globally confirmed, and about 1.7 million deaths have been reported. In UK, we have about 2.2 million confirmed cases, and about more than 70,000 deaths have been reported. So since then, there are so many management or a treatment trial come out, but we didn't know the actual treatment for this COVID. At that time, the issue of the vaccination is started, but there were no record or reported that any vaccine come down. So from 3rd of April 2020, the UK started a trial, which is called a randomized evaluation of COVID-19 therapy, which we call it COVID recovery trial. So up till now, we got some results of it. You may heard about different medications have been trialed, like hydroxychloroquine, and it showed that there is no clinical benefits. Then dexamethasone came out on 16th of June, and it shows that it has reduced the death up to 1/3 of the hospitalized patient. There is another medications like lopinavir and azithromycin, which shows there is no clinical benefit. Still, the recovery trial is currently testing some of these treatments, and it's under a trial. So we still need to wait for all the results to come back. Remdesivir in USA, there is a big trial which suggests that it is reduced the recovery time, but there is no survival benefit. And drug is approved in the NICE, and which we are giving in our hospitals. So I will go through cases and just to try to explain you what we are treating now at the moment in the hospitals especially. So first of all, everyone know that asymptomatic disease, the cases are of SARS-CoV-2, like COVID infection. It does exist, and the patient doesn't have they don't have any symptoms. So definitely we don't treat, it's just a symptomatic treatment isolation. If I go with this case, it is a real cases that 30-year-old male, no known comorbids, 2 days history of fever, cough, body aches, saturation of 98% on air, with no shortness of breath, and come to the accidents and emergency department. So we saw this patient, and we think that because of the pandemic, more likely it is a COVID infection. So definitely this is a mild disease, and we don't need to admit this patient. So we treat as mild disease. We send the throat swabs, no bloods needed, supportive care at home, and oral hydration and paracetamol, and send home and give their safety advice. So this patient can be easily treated in community by the GP itself also. There is another case, 55 male, Asian background, type 2 diabetes, hypertension, current smoker, and he has got a 4 days history of fever, body aches, breathlessness, you can say loss of sense of smell and taste also, and sets our oxygen level is a bit low, 92% on air. So below 94 in a healthy other people who don't have any lung problems, it shows that it is a low saturation. Chest X-ray shows that bilateral infiltrate, which is suggestive of pneumonia. So this type of patient, we call it the moderate disease, in which they have fever, cough, dyspnea, fast breathing, but no signs of severe pneumonia. So we do the preventive, we admit these patients, we do all infection control prevention, bloods, oxygen, antibiotics, anticoagulation we give, we ask for the proning also, like lying on a belly, we monitor for deterioration, escalation plan, and since we know that remdesivir and dexamethasone came in, so we start these treatment, and once they're recovered, we discharge safely with some advice, and if needed, they need anticoagulation for 1 month. Then there is another case, which is 62-year-old male, background of type 2 diabetes, hypertension, heart problems. He was a director of a company, and his CFS is a clinical frailty score, and we do according to their how much they're mobile and active. So he's quite a pretty good man who has got good quality of life. Presented with 7 days history of cough, fever, body aches, short of breath last 2 days. He has got low oxygen saturation of 80% on air. He's got chest X-ray, he's got bilateral infiltrate. We call it pneumonia up to the mid-zone, mid-lung. So definitely he's very poorly when he came near any, and he needs some more invasive support. We call this as severe pneumonia, and which you can see the chest X-ray involving more than 50% of the lung fields. They're called severe pneumonia with low oxygen saturation. So what we do, we give the initial treatment as moderate disease. We give the oxygen, very high flow oxygen, bloods, antibiotics. We give IV fluids, we give dexamethasone. We start anticoagulation, remdesivir. We send the COVID swab test. In some of the hospital lately, we started a lateral flow antigen testing, which is available within 20 minutes. So antigen test was positive, and chest X-ray and ECG. The patient become more breathless and drop oxygen saturation while in ED to 88% on 15 liter. So seems like he was very unwell. So he involved the intensive tertiary unit people. They decided that this patient should go to the CPAP, which is a non-invasive ventilation approach. And later on, while he's in ITU, we found that patient has been intubated and ventilated. He developed multi-organ failure in which more than one organ's involved. His kidneys were shut down, so he required 3 sessions of dialysis. It got a very slow recovery and he stayed on ventilator for 20 days. When he stepped down from the ward from the ITU, he was very weak. He developed a condition which is called critical illness neuropathy, in which the muscles are so weak that he can't be able to mobilize by its own. He has got intermittent confusion, has got post-traumatic stress illness, which is quite common in ITU people. Then he discharged to the rehabilitation unit. And 3 months of discharge, he was found that he is only mobilized on the Zimmer frame. He's very weak, definitely lost his job. He has got multiple admissions with infections and fall, and still he has got depressions. So in a view, if you see that if somebody developed these things, 5% of the patients who are critical illness, they ended up with this scenario. Definitely, it is a dangerous disease if it comes to the population. And only thing I think we all doctors, all the health professionals, all the politicians, they are saying that we need to avoid getting this infection. And this is the main theme of all today's talk, that we need to aware the public that most important thing is that the coronavirus is still existing. It is still there. A large number of yours and my friend family members suffered this illness and some have sadly passed away. We, the healthcare professionals, still facing the cases every day and proud to treat the patient, even risking our lives. A large number of them died. If you want to save yourself and your loved one, this is the take-home message. Please follow the guidance. Wash your hands, cover your face, social distancing, and definitely please get vaccination. So I will leave it my talk here because definitely the question and answer come, especially from the clinical aspect of acute medics. So I will be happy to answer these questions. So back to Dr. Tariq. Thank you much.
Thank you, Salman. You've given us a good insight about the consequences of having COVID-19 and what the patients go through with such a devastating at the end, some of the patients may find in themselves. So I think I will just to highlight how the importance is still these preventive measures, although we are basically talking on the vaccine. And I will now invite Dr. Mohammed Raza Naqvi. He's the consultant virologist at Sheffield Teaching Hospital, Royal Hampshire Hospital, to give a talk about the vaccine and the virus itself. So I will, without any delay, I will ask Dr. Raza Naqvi to start his presentation, please.
Right, failed the unmute test to start with. So thank you very much for asking me to come and give the talk. Can you hear me, guys? Okay, so please say so if you can't.
Yes, we can hear you.
But if you can, I'll just thank you once again for asking me to give this talk. And what I'm going to do is I'm just going to limit myself to the vaccines, the way they work, and some of the aspects which public find little knowledge of, and I'm just going to try to give you the context of what these vaccines are, what these vaccines are supposed to do, and how to make some sense of the data which is being thrown at us from all sorts of various sorts. And we find it very, very difficult because sometimes it's not easy to find out what the agenda is from the other person. One of the things, I'll go back to what Salman was talking about earlier on. The 2 cases he presented are very good examples of where the healthcare has been currently focused. Now, what do I mean by that? So what Salman has presented is the delivery of healthcare. And the overall population health has got more than one component, which is the healthcare delivery and the population health. All the expenditure you talk about, all the expenditure you think about in the context of healthcare, you usually talk about the delivery of the healthcare. If you step back slightly and look at what your responsibilities are as the healthcare providers as the government, as different societies and population executive is to look after your population, which includes prevention of disease. Now, this has been successfully demonstrated by a number of campaigns. To give you an example, the smoking cessation campaigns linked with lung cancer. Another good example is the human papillomavirus vaccine and the disappearance of the cervical cancer. And that has all taken place at the back of these preventive measures where you stop the cause of the illness before it becomes a problem. Because once you are in the middle of the crisis, then it's very difficult to actually solve the resource and the delivery, the disproportionate, let me rephrase, the disproportionality between what is available to you as a resource versus what you need to do can be quite debilitating, especially for the resource poor countries. So what I'm going to do in my talk, let me just see, is to give you a brief description of the immune system, how it works, what the components of a vaccine are, especially in the context of today's talk, that of the mRNA vaccines. What do we mean by mRNA vaccine, and what are the other types of vaccines? And what vaccines do we have for COVID-19? And how does the mRNA work in the context of vaccination? And what are the different trial phases, and how do we assess the safety concerns? Now, if you look at the various different systems of the body, and we do have, most of us will have a basic understanding of what the body systems are. And what I've shown you a picture of is a blood vessel, which is shown predominantly the red blood cells. Now, if you look at the blood vessel in itself, you will also find some other components, which in addition to the red blood cells have got the white blood cells, the platelets, and some of the other proteinaceous components in addition to the food material, etc. But the castle of protection to the human body is provided by the immune system, which is comprised of these important cells, which I've just showed here in this slide. Now, these have got different terminologies. Some people call it the phagocytes. Some people simply refer to them as white cells. For some, it's the basophils and the eosinophils. But what I want you to remember from this slide is that the mechanism by which the immune system works, or the body protects itself against various pathogens or various insults, is the immune system, which comprises of these basic cells, the white blood cells. In addition to the white blood cells, you've got some proteins in the body, which you call the complement system. Now, the idea behind the complement system is that these proteins are just alerters in a way that they find the intruder, which is a pathogen, for example, in this case. It then just calls all the other components of the immune system towards the site so that the intruder is taken care of, is killed before it causes much damage. The complement system has got its own role in the whole immune pathway. Let me go back to the first slide and just take you back to the word phagocytes. Phagocytes are just cells which kill the intruders, whether it's the infection organism or whether it's the cancer cells, for example. These are all called phagocytes. And these phagocytes have got different components. Some of them are very fast and quick moving. So say, for instance, you imagine a new infection which enters the bloodstream. It will take some time for the body to develop the right amount and the right type of armament to fight that particular infection, because the body hasn't seen that infection ever in its life. So what it will do is it will start manufacturing the process of making those defense mechanisms, making those arms which will effectively take care of that organism. But that takes time. Imagine a factory where you ask something brand new to be built, something which has not been designed before. It will take, there will be a lead-in time, whether it's days, weeks, or months. It will be not straight away. So to counter that immediate lead in time, you've got some fast moving cells which go to the site of invasion, and they have got a generic role where they take care of the damage and just try to limit it. These are very, very fast moving, and they're called granulocytes. The main component where the infection is taken care of are the macrophages, which are big eaters, but they take time. They are heavier cells which take, you know, minutes, hours before they can arrive at the site of their demand. Dendritic cells are the antigen presenting cells which are hovering around in the immune system, and what they do is they are on the lookout for any new invaders. They capture that invader and they present it to the immune system, for example, the granulocyte, and to say, look, I found this particular invader. I do not know what this is. Could you please have a look? And what then typically happens is, you know, as part of this presentation mechanisms, the dendritic cells, which are called the antigen presenting cell, it just eats up that bacteria in this example, eats up the bacteria. A component of the bacteria is then digested and is taken to the surface of the cells, which then is what you can call as it's expressed, the antigen expressed on top of this. This particular dendritic cell then goes all the way to the other part of the immune system, which are called the helper T cells. Now, as soon as the helper T cell recognizes an antigen, it becomes activated. Meanwhile, what's happening is there are other cell lines, a type of lymphocyte, which is called the B cell. It's just on the lookout for, it's just leisurely looking at various antigen it comes across and is trying to find the best fit and to plan the best mechanism of taking control of that. When it's triggered by the T helper cells, it just differentiates into producing antibody as part of its attack by differentiating into plasma cell, and part of it converts into memory cells. And the importance of these memory cells is where the vaccination concept is very important. So the plasma cells throw the antibodies at the invaders, and the memory cells keep all that planning in the memory, so that if the invader was to come back again, it can start producing this. Now, there are other components of this, which I'm not going to go into detail, but one thing you have to remember is that the memory cells are quite important in this whole pathway. So how do the vaccines work, and how does that relate to what I've just said? What you're effectively doing in this is, in the vaccination program, is you produce a vaccine which has got an antigen which you introduce into the body, which is then taken up by the immune system. The immune system develops antibodies and the T cell responses, and therefore has got the plans to fight the infection when it's required. And that's where you say the person has been immunized. Now, it's easy for me to say you create or manufacture a vaccine. There are a lot more details which have evolved over the last few decades. And I think you can even call it centuries, because generally in the days of cowpox and smallpox, that's where the live vaccines came in. And over the last more than 100 years, you are now looking at 4 distinct type of vaccines. One of them is inactivated vaccine. So instead of introducing the wild type vaccine, which can cause disease, what you do is you kill the pathogen and then you introduce it into the body by injections, by taking it orally, or by the intranasal drops, which are examples of live vaccines. However, in some of the cases, what you can do is you can weaken the virus or the pathogen to such an extent that it cannot cause disease. The subunit vaccines, on the other hand, is that rather than giving the full pathogen, the whole pathogen, you just take a component of it, you just manufacture that part, the antigen, and then use it to make the vaccine. And then the nucleic acid vaccine, which I'm going to go into with more detail. Now, another type of terminology, or a set of terminology you will be coming across with the release of more vaccines for this infection, of the viral vector vaccines. And what you do typically in these examples is that you take an infection which is quite harmless for the humans, which has been proven beyond doubt. You import or you integrate part of the messenger RNA or part of the DNA from the target vaccine, target pathogen, and you make a new virus, which you call the delivery viral vector, which is then injected into the human, which then leads to the production of the immune system. Because when this particular viral vector goes into the body, it starts to produce the proteins which are necessary for the immune recognition, and the rest of the process is the same. One of the important things people are confused about, and they keep on asking the question, is what is this? What are the components of a vaccine? Does it mean that the vaccine is all about a pathogen and it doesn't have anything else? And the answer is, in this particular lovely cartoon, which the immunology.org, the Society of British Immunologists, have come up with, and I'm just going to use this to demonstrate what is the component of a vaccine. You can see here the orange bit is what the main and active component of the vaccine is. It could be a kill virus, it could be just the messenger RNA, it could be a live but weakened virus, which forms the main component, the immunogenic component of the vaccine. Now, of course, on top of that, there are some other components which have the cause of some controversy, but the biggest ingredient of the vaccine is the water. You have to stabilize and preserve the vaccine, prolong its life, and you have to add some components to it. And good examples are sorbitol, which are naturally found, for example, in food in large amounts. You also have the adjuvants, which create a strong immune response to the vaccine. They do not pose any significant risk to the health, because these are the compounds which occur in nature. For example, one of the antacids is aluminium. For example, aluminium exists in drinking water at much higher levels than you see in the vaccine. And then there are some residual traces, for example, formaldehyde, which some of you may think that this is a chemical which is very dangerous, but you may be surprised to know that it's actually found in the human body in higher concentrations. The other thing which I thought will be quite interesting to clarify is the use of the word nanotechnology or the nanoparticles. What is the background behind that? So if you look at the scale of measurement, and if you just look at the humans, the average height 1.8 meter, which has been shown in this diagram, if you just go down the scale, you'll come across a point where beyond which the human eye cannot see. And then if you keep going down towards the other end of the scale, you'll come across a point where even a microscope cannot see anything. And it's after you cross the 100 nanometer limit and go all the way further down, that's where this is what you refer to as the nanometer zone. Anything which is less than 100 nanometer is typically called a nanoparticle. So basically what we are saying is that whatever nanoparticles you come across are basically the size is what you're describing. They're very, very small molecules. So the component of the vaccine which has been released, which has been given to a lot of people, which is called the Pfizer BNT162b2, it has got a very basic structure. For the sake of understanding, if you just think of it, it has got a core which contains the messenger RNA. This is surrounded, for the sake of stability, by the lipids in the form of nanoparticles. So they're very, very small particles, but essentially it's fat. It's then surrounded by another compound which is used elsewhere as well. It's not specific to this vaccine. It has been used in other vaccines. It exists in common household materials, for example, toothpaste, and that's called polyethylene glycol. And the reason why you should know about this is because PEG has been implicated in some of these anaphylaxis reactions in some individuals. So for that reason, what has been advised is that if you have got allergies to any other drug, any other food components, etc., that you're not given the vaccine. So in a way, you can say it's contraindicated, just to be on the cautious side. It doesn't really mean you will have it. So let's come to one of the important questions, which is that how does the messenger RNA work? And for us to understand that, we have to go back to the basic physiology of a normal cell, whether it's a human cells or any other animal species. What if you go back to your GCSE knowledge, you will remember that the cell comprises of a cytoplasm, an outer cell membrane, and an inner nucleus. What the nucleus holds is the DNA, which is the command center. So the command center has got direct control of what happens in the cytoplasm, where all the machinery is. This machinery mainly, or more importantly, has got ribosomes, which are protein manufacturing units. So they produce amino acids, which then combine to form the proteins. So the messaging from the DNA, the control center, to its factories, ribosome, is through a very typical chemical, which is called the messenger RNA. Basically, it's taking the messages from the DNA all the way to the ribosome to say, I need this protein to be made. And that's what the ribosome does. So what you're doing as part of this vaccine is, instead, you're just producing a specific messenger RNA, which is absorbed by the human cells. It comes directly to the ribosomes, and it starts producing the protein of the virus you're interested in. It does not produce the whole virus. It does not produce anything which is capable of producing an infection. It just produces the protein, in this case, the spike protein. This messenger RNA does not go into the nucleus. It has got no effect on the DNA and is incapable of doing anything else because it disintegrates relatively quickly. This is a 3D presentation of the same thing: nucleus, messenger RNA, ribosomes, and then proteins. So I'm talking about the messenger RNA and the vaccine. So how do I know it's safe? Now, for me to know for sure that the vaccine is safe is to see exactly how they produce this vaccine. And for any vaccine to be produced, you have to take it through a specific Dr. Tariq, can you just control this? Somebody's just messing the screen up here. I don't know how that's happened, but some people do that. So what you have to do is you have to take it through various phases of a clinical trial, and typically it's 3 phases, 4 phases, and sometimes there's a phase 0. So in phase 0, what you're doing is you're trying to find a protein which will be effective in producing an immune response. In phase 1, you give that particular drug which you found, or the vaccine which you found, to a group of, say, up to 100 people and see exactly how it behaves. You find what the right dose is, and then in the next phase, you expand it to hundreds of volunteers to further fine-tune the dose and see whether it's effective or not. You then take it to the phase 3, which is thousands and thousands of different volunteers. And the whole purpose of this is to see whether it's safe, whether it's effective. And you can see here how this all expands into phase 3, the number of people involved. And then even after phase 3, once it's been released for general use, there's the phase 4 post-marketing surveillance, which is actively looking out for any safety concerns. This is not vaccine specific. It happens in all the trials and all the drugs. So has this vaccine been developed very quickly, and how can we know it's safe? Now, this is from a very reputable source. I think it's from the WHO website. And what they are talking about here in a very diagrammatic way is how long it takes for a typical drug or a vaccine to develop. And you can see here, there are very long duration of exploratory and preclinical phases, which are then converted into clinical development. Ultimately, in 10 to 15 years, you just manufacture the drug or the vaccine. Now, what you have to remember is this is a commercial venture. What you have done here is got a lot of red tape, and a lot of organizations, a lot of governments have joined hands, and they have reduced this process from 10 to 15 years to 1 to 2 years as a minimum. What we've seen in our current vaccine, this has been cut down further. So that's how you get to get this particular vaccine in such a timely fashion. Somebody's telling me how to spell COVID, that's okay. Right, this slide has been quite widely circulated, and what you have to understand here is how to interpret data. And it was quite interesting to note that the person who was trying to translate the health impact events into disability did not do it properly. Now, what you have to look at when you're reviewing the safety data or the safety aspects of a vaccine is to look at its adverse events. Now, what do I mean by adverse events? So there are different classifications when it comes to look at the safety profile. Now, adverse events versus adverse reaction are completely two different phases. So if I was to give you an example, a hypothetical example where you are vaccinating people and it happens to be a very slippery slope, and people who are coming for vaccination, they slip, they fracture their femurs or fracture their legs or the hands, those automatically become adverse events, but they're not linked to the vaccine. For it to be causally related, you have to look at the adverse reaction. So what that means is you will see a lot of adverse events. Some of them will be suspected adverse reaction, but only a relatively small minority will be causally linked for it to be termed as adverse reactions. So you just have to be very careful when you're interpreting the data. So there are about 58 candidate vaccines, and what we've known about is the approval of the Pfizer, BioNTech, the Moderna TX vaccines. But there are two further vaccines which are in the pipeline, the Oxford AstraZeneca, which is a vector virus, adenovirus CHAdOx1 vaccine, and Johnson & Johnson is also in phase 3 of the development of vaccine, which again is a vector vaccine. And this is a summary of what the trial is all about. I'm just going to rush into the details, but I can take answers later on. But you can see here the number of people who got the infection after the vaccine versus those who did not or got the placebo. There's a stark difference between those who got it and those who did not. And I'm just going to just cut it short here slightly, running out of time slightly. But this is a very good example of what happens when you introduce a new infection in a very susceptible, vulnerable population. And you can see here the historical perspective of the HMS Dido, which brought troops to an island where people had not seen measles. And about 20,000 people were killed, which was about 1/3 of the island's native population. But now with the MMR vaccine, you are able to protect yourselves, your population from measles, rubella, and all the other sorts of infections which you see. So what I would say here is that you have to really consider all these vaccines in the context of what is happening in the outside world. Pandemic is an emergency, and you can't really just look at the very, very small numbers, the minute details, and then try to have preconceived ideas without looking at the actual data. A lot of damage has been done in the whole COVID pandemic, not just the vaccine, by social media, non-peer-reviewed articles, and the WhatsApp groups. So what I would say is do your own research, listen to the specialists, and consider the role of the government. They have got public offices and they do have responsibilities against it. So just be a bit kind. Over to you, Dr. Tariq.
Oh, thank you, and Dr. Raza. You explained very nicely all about the pathway from the vaccine, from the immunity to the vaccine, and the side effects and the way it manifests, and some of the misconceptions about the vaccine you have nicely highlighted. I'm sure there will be still some questions at the end. So to keep the time going, so now I will introduce our next speaker. He's Dr. Wajid Akhtar. He's a Vice President of British Islamic Medical Association, which is promoting the Muslim values in health professionals and helping the wider community with the charitable activities locally and globally to help needy irrespective of color, creed, and faith. And Dr. Wajid himself is a GP in Essex, and he's a medical tutor in social media and medicine and history of the medicine at Barts and the London Medical School. So he's also on editorial board of Muslim Matters and frequently write on Islamic history for various Muslim blogs. And he's also the founder of the Charity Week and National Fundraising Initiative. And so without any delay, I will ask Dr. Wajid to give the perspective from the British Islamic Medical Association. They have presented a statement, so I would like him to share with all of our audience, please.
جزاك الله خيرا. السلام عليكم ورحمة الله وبركاته. الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه وسلم وعليه تسليما جميعا كثيرا. So thank you very much to my previous speakers who have given us a really good detailed background into COVID, the disease, and the vaccine. So now I guess the question you want to know is, should we take it? And who should we trust nowadays? Because as the Muslim public, you know, up to now, what do you have to do? You have to, you know, you don't have a friend who is a virologist, or maybe you don't have a friend who's a doctor in that specialty. So who do you trust? Who do you go to? And at the end of the day, most people, they go to this friend, the best friend for everyone, WhatsApp, right? That's where people go, social media. So-and-so said this, so-and-so said that. And we see that a lot of information and misinformation is being shared there. So I'm going to make a case that actually there is somewhere better to go than WhatsApp. And this is where BEMA comes in. Who is BEMA? BEMA is the British Islamic Medical Association. What this means is that any Muslim healthcare professional, pharmacist, dentist, nurse, consultant, doctor, medical student, whether they are from Nigeria, Pakistan, whether they are Hafiz Quran with big beard, whether they don't have that much Islamic knowledge, it doesn't matter. From whatever part of the country and whatever background, we have come together. We're coming together under an umbrella, and we are sharing our strengths and we are decreasing our weaknesses between each other. The aim is that as a Muslim, as a British citizen, that if you want healthcare advice specifically for our community, then we should be able to give this to you. And there are many other beautiful organizations out there, APS, APNE, Nigerian Doctors Association, Sudanese Medical Association. So there are many other out there as well. We're not the only one, and I want to make that clear. A lot of people doing good work. But what have we been up to in this pandemic? Because in this pandemic, we've done a lot of activities. So for example, we have provided advice to the scholars, Islamic scholars. We have provided advice about what the Muslim community needs are to the NHS England and to NHS more widely. We've helped pressurize on visitation rights, that you can't, you know, hopefully people should not be dying alone in hospital. At least allow one person to visit, give them the PPE. We've been advocating, we work very closely with Muslim Council of Britain to advocate Ramadan at home and to celebrate Eid at home, because that would be safer. We're talking about how to do ghusl. So we work with the National Burial Council for Muslims on the safe way to do ghusl on even COVID positive patients, so that we can bury them properly. Is there enough burial space? And we review for Ramadan and mental health advice. There's a lot of different activities been going on. But the big thing that has happened, which many people are not aware of, is that at the start of this pandemic, the Muslim organizations, whether scholarly organization, whether Islamic organization, whether medical organization, charities, TV channels, economic, burial, mental health, they have started to work together and united like they have never been before. This is the Muslim National COVID Response Group. It's chaired by the Muslim Council of Britain. There is a medical response group, scholars, publicity, charities. And what happens is that, I'll give you an example. If there's a medical issue, like the vaccine, should the scholars and the publicity people, the charities, everyone wants to know, should we trust it, should we not trust it? So they ask here in the medical COVID response group, where we sit around with a group of people, a large group of people, inside, outside BEMA, and then we advise the community, we give our recommendation. And that was happening with many things. Should we close the mosque or should we not? That's where we make that decision or discussion. Should we push the government to open up for Eid or should we not? What should we do for X and what should we do for Y? This is where these things are discussed. Similarly, you know, the cremation issue was discussed in the burial, and how we should respond as a community to the economic impact was discussed here and here. So alhamdulillah, there's a lot of coordination. So when it came to the vaccine, we didn't sit down and just one person, you know, just Dr. Wajid likes vaccines, so he's going to tell everyone, take the vaccine, trust me, I'm a doctor. It wasn't like that. We had virologists, infectious disease specialists, people who are scholar medics, so dual accreditation. They are doctors and they're also alim-e-din, both. Researchers, bioethicists, intensive care specialists, medical specialists, international experts. So we spoke to our colleagues in Malaysia, Canada, America, South Africa, Nigeria, Pakistan, those who have dealt with the Medical Health Regulatory Authority, people who know the system of what it takes to take a drug from inception to licensing, pharmacists, Muslim community leaders, scholars, and so on. We discussed with all of them and they discussed together, and we looked at the pros and we looked at the cons. What are the pros? What are the cons? What is the advantage? What is the disadvantage? What are the things that could be done better? What things that we are worried about, specific to the Muslim community and general for everyone else? After we did all this, we analyzed and we looked at the balance. This is what we want you to do. On this side, there are some temporary reversible side effects. Every single medicine, every vaccine has a side effect. There is nothing that does not have a side effect, but temporary and reversible. So far, nothing has been shown to be irreversible. Nothing has been shown to be permanent. Unfortunately, there are a lot of videos spreading around WhatsApp and they are lying. There's no other word for it. It's not like they're misunderstanding. They are deliberately, time after time, lying and talking to you about irreversible side effects. There has not been shown. Now, we don't know what the long-term side effects are because the long-term has not happened yet. Nobody can see into the future. You will know the long-term side effects once they're gone, and we do not anticipate dramatic long-term side effects based on the medical information that we have in speaking to all the specialists in those areas. That's on one side. The other side, which is never talked about when they talk about the issues, is what is the other side? When you take a balance, you don't look at only the negative, right? If you only look at the negative, then don't drive, because you will only look at the people who die of car accidents. You only look at the cost of driving. If you look at only the negative, then don't fly. If you look at only the negative, then don't do anything, because then you're not looking at the other side of the scale. It is unbalanced. But if you want to look at it balanced way, now look at the other side. 500 plus deaths per day. Few days ago, it was close to 750. That means at least every single night, 2 airplanes are falling out of the sky. That's how many people are dying. And people try to minimize it. 1 in 1,000 people in this country have died from COVID already. 1 in 1,000. That does not even include the long-term side effects. When people have long COVID, what it does, the damage it does, we don't even know yet. There are some studies that say that it might reduce your life expectancy by 10 years. And don't believe the lies that it's only the old and the sick. They are there are 30-year-olds, 40-year-olds, 50-year-olds, and sometimes even children who are dying from this disease. Majority old and sick does not mean it is only old and sick. And by the way, when they say sick, it means any pre-existing condition, diabetes, asthma. That means almost 40% of the population has something. So the other side as well, long-term side effects and the mental health and economic impact. We cannot keep living in lockdowns for the rest of our life. We cannot do this. It is causing serious issues. As a GP, I'm seeing 7-year-olds who are suicidal. How is this possible? They don't even know how to spell the word suicide. So now look at the balance. And when we look at the balance, it's very, very difficult not to see that the heavier scale is on the side of what is the known, not side effect, the known deaths, the known issues, the known impact versus the reversible, short-term and unknown. That's what when we looked at all that, we provided a summary, a detailed statement. It's on our website, britishima.org, and a summary statement, which you can find online. It's a summary. It just puts down very briefly what is our recommendation. This is our recommendation. This is not an order. No one is putting a gun to anyone's head. You have to take the information and decide, but you should decide as well that are you going to trust the vast majority of Muslim healthcare professionals of all grades, types, and sizes from your community? They are human beings like you. I have had the vaccine. We have to give it to our parents. Are you going to trust them from all across the world? Are you going to trust the scholars and the ulama? Or are you going to trust so-and-so on WhatsApp? That's the decision that needs to be made. And it's a life or death decision that you are making. So make sure that you choose to trust the right people. Allah subhanahu wa ta'ala says in the Quran, فَاسْأَلُوا أَهْلُ الذِّكْرِ إِن كُنْتُمْ لَا تَعْلَمُونَ. Ask the people who know if you don't know. Ask the people. You should know this, right? This is Islam. Our Prophet ﷺ, his cousin Sa'd ibn Abi Waqqas anhu, came to him, his relative came to him with chest pain. Our Prophet ﷺ could do anything. He can split the moon in half, right? He put his hand on the chest and he removed the pain, but did he stop there? No. In every other religion, you would stop there. He cured it. He said, now, words to the effect, now go to so-and-so person in that tribe, I think it's Kinda tribe. He is an expert in dealing with this. As in he has the medical, as much as they had at that time, expertise in dealing with this. So the Prophet ﷺ referred his own relative to someone else, to a doctor, to someone with the knowledge of how to treat diseases. So do the same. When you have it, don't refer to WhatsApp, don't refer to Google, ask your questions to your local doctor, to your local scholars, and inshallah, that's the key message that we have for the Muslim community, that please make your own decision, but we pray that you make the decision based on good information. Jazakallah khair.
Jazakallah khair, Dr. Wajid, for your excellent presentation and details about the vaccine and Muslim perspective. Now, I will ask our last speaker, Dr. Amir Hanan, to give his perspective. Dr. Amir Hanan is a full-time GP at Houghton Thornley Medical Center in Hyde, and he's a director of the local GP Federation, and he's a chair of West Pennine Local Medical Committee, and he's chair of Greater Manchester NHS Values Group, and chair of the World Health Innovation Summit. So I will welcome Dr. Amir Hanan. He has kindly given the talk before as well when the COVID-19 started in March, and now this is a follow-up talk, and it's a great pleasure to ask Dr. Amir Hanan to present his GP perspective.
Can you hear me now?
Yes, we can hear you.
Okay, thanks very much, Dr. Razak, for inviting me to come and speak. And I've just been looking at some of the questions that are being posed in the chat, and hopefully my presentation will give the GP perspective on the COVID-19 vaccination. As you say, I'm a full-time general practitioner in Hyde in Tameside, and I thought it'd be useful to describe what my experience is as a GP in my own practice, and by reflection, we can talk about what this means for wherever people are throughout the UK. I should say I'm not an expert on COVID-19 as well. I'm an expert in my expertise lies in general practice. But it'd be useful for you to have some context of the kind of population I'm dealing with and how it relates to COVID-19. So we have 13,150 patients registered as our practice. We've got 7 GPs, 4 nurses. And again, that's useful for us to think about the context of, we have 11 healthcare professionals who are looking after 13,150 patients. And sometimes we forget how important that is when we start thinking about how we deliver care. It's a semi-rural practice in Hyde, in Tameside, in Greater Manchester. It's a very deprived area of Greater Manchester, where on average, my patients, even before COVID-19, were dying 10 years younger than the national average. And the reason for that is because, unfortunately, there are very wide health inequalities. There was already a significant unemployment amongst my patient population, which sadly over the last year has greatly worsened. And many of my patients are now unemployed as a consequence of losing jobs and things. Massive socio-economic deprivation that exists amongst that community. And again, these are factors that we need to think about, because COVID-19 is not just about the health impact, the impact it's had on communities and work has been absolutely massive, which we are then going to have to deal with. The consequence of this very poor socioeconomic deprivation is that their quality of life is extremely poor. And again, for those of us who don't know what really that means, if you're living well and don't have any health problems, you might continue to live until you're 60, 70 years of age, and then you might start with high blood pressure, maybe some diabetes or whatever. My patient population, on the other hand, is starting with conditions when they're 40 years of age and starting to become unwell with angina, with COPD, which is a chronic chest condition. And they may well live for 20 years, die early in their mid-60s, early 60s, but they've lived for 20 years with poor ill health, in and out of hospital, coming to the surgery, taking multiple medications and things. So they're already enjoying a poor quality of life even before COVID-19 came along. They've got poor housing, often multiple people living in small cramped houses, which again means it's difficult for them to be able to protect themselves from other people and picking up problems. We used to have a smoking factory until only about 10, 15 years ago. And so within the population, we've got a very high rate of smoking. Something like 25% of the population of Tameside smokes. And again, all the consequences of as a result of smoking. A very sedentary lifestyle. Most people are not out and about walking, exercising, running, going to the gym. They're sat at home watching TV, eating McDonald's or fast food or whatever it is, which again leads to other problems, particularly long-term conditions, diabetes, depression, problems with back pain, hip pain, neck pain, knee pain, and so on, which again further exacerbates, making it more difficult for them to actually get up and move and do more exercises and things. We've in fact got the highest level of heart disease in the UK, and that's by the British Heart Foundation, who noted that. And it's a consequence of all the things that I've just described above you. And a very high proportion of people who are overweight and obese. We've got a large Bangladeshi population, about 1,500 patients, many of whom, again, don't speak a word of English. So big issues around how do we try and inform them and educate them about how to look after themselves. And the consequence of all this is very low levels of this idea of health literacy, their understanding of their health and well-being. But I do put in there, but improving. I've been a GP now for 20 years in this community. It's been an absolute pleasure for me to try and help this group of people. And I'd like to think that I've made a small little part in trying to help them improve their chances. But as you can see, these are things that they were dealing with before COVID came along. And in fact, when you start looking at the papers and start looking at which groups of people are doing worse, it's these groups of people that are now starting to come out, and we're starting to realize these are the ones who are more likely to have problems and more likely to have the severe complications that Salman was describing earlier. And then finally, we've been in tier 3 lockdown for, it seems like an eternity, for months and months. So people in these conditions have been stuck in their own homes, not being able to go out, not being able to meet other people. And that's had a devastating impact, not just on their physical health, but their mental health as well. And you can then start to understand some of the pressures that I as a GP have in trying to support these patients, whilst at the same time hearing all those messages on WhatsApp and whatnot by people who are not actually responsible for delivering care to these groups of people. And these are the very people who've been affected by COVID-19. So how many of our patients have been affected by COVID-19? Well, out of the 13,150 patients, and I did a search this morning on our computer system, 477 patients currently who are alive have tested positive for COVID-19. That's 3.6% of the patient population in our practice at this moment in time. And remember that we've had a large number of patients who've died as a consequence of COVID-19 itself. And I've had to deal with the patients and their families, and within the community itself, the impact, the devastating impact that COVID-19 has had. People are frightened and scared and wondering what to do. And they're looking to the leaders in the community. They're looking to us as GPs, who are those pillars in that community, to try and advise them in terms of what to do. But whilst we talk about morbidity or death, unfortunately, it's not a matter of you either live or you die with COVID-19. We also know that a large number of people are also affected by COVID-19 who don't die of it. These are the 477 patients that we've got, but actually are affected by it. And I thought this quote by Dr. Srinavan, who's an associate professor and consultant in public health, is something that really resonated with me, because COVID-19 leads to ill health for many months in at least 10% of people who get it. It affects their ability to look after themselves. It affects their ability to care for other people. It affects their ability to work, and it affects their ability to exercise. And most definitely as a GP, I've come across large numbers of patients who are affected by this. If we just take that figure of 10%, then out of the 477 patients that we've got, that suggests something like 50 of them are currently experiencing the kind of problems that we're describing here, finding it difficult to look after themselves, caring for others, working and exercising. The things that most of us just take for granted, they are finding very, very difficult to do. And our job is to try and support them, and hoping that whilst we try and identify a cure, that we can help them keep going, whilst their mental health is affected, whilst their physical health is affected, whilst their relationships are affected, whilst their children are not being able to enjoy their parents in the way that they would have liked. You can imagine the impact that this is actually having. And that's my work. That is what I am dealing with as a GP. As I go into work tomorrow, these are the groups of patients that I'm thinking about how to support. So what do we know works? Well, we know if you wash your hands regularly, you are less likely to pick up the COVID-19 vaccine. Wearing a face mask is not about protecting yourself. It's about protecting all those around you, so that they don't get the COVID-19 from you. And again, it's vital that people wear the face mask when they go into enclosed places at the moment, whether it's walking into GP surgeries, whether it's walking into hospitals, or also if it's going into shops. It's not just it looks cool or whatever. This has been shown to reduce the risk of it being spread. And then finally, keeping that distance away from other people as much as possible, rather than being together. When I was looking at pictures of what was going on at the Trafford Centre on Boxing Day, and there was people weren't wearing face masks, people were not keeping their distance from other people, it really saddened me, because I'm sitting there thinking, these are the very people who are going to get COVID-19. We're going to have to care for them. And sadly, some of them will die as a consequence of the COVID-19. So these simple actions really make a big difference and save lives. And that's what it's about now, it's protecting people and saving lives. So in terms of the vaccination, as a GP, what do I think people need to know about? Well, the first thing I'd really encourage you to do is to think about what is your own personal risk of developing COVID-19? What are the risk factors? Again, being over 70, overweight, having diabetes, and there's a variety of other factors that I've talked about earlier around your chance of getting COVID-19. You should think about it yourself, so that in your own sense of, am I low risk, am I medium risk, or am I high risk? Are you following the guidance to stay protected, or are you taking risks? We know that only 10% of people who were identified by track and trace as being contacts of someone with COVID-19 and were told to self-isolate for 10 days. We know that only 10% actually followed those rules. The other 90% didn't follow the rules and stepped outside. And by doing that, you've increased not only your own risk, but other people's risk of contracting COVID-19. So again, thinking about those people that are supposed to be self-isolating, have you kept away from them? Or have you continued to meet with those people? In which case your risk perhaps is just a little bit higher than the average. Do you know the symptoms of COVID-19, i.e. a persistent cough, a temperature, loss of taste, loss of smell? There are other symptoms you can get, headaches, diarrhea as well, skin conditions and things. It's important to know what those symptoms are, because if you start to develop those symptoms and are worried it's COVID-19, do you then know what you need to do as a consequence of that? Phone 111 if you're not sure. If you need to be tested for COVID-19, then contact 119 or phone 119 or go on the website, the NHS 111 website, so that you can then book yourself for it. And if you're considered within what's considered a high-risk group, then you may well need to be put forwards for the COVID-19 vaccination. And the Joint Committee for Vaccinations and Immunisation has provided this guidance. Whether we write it or not, this is what they've decided. And they've decided that the first group of people that we need to vaccinate are those who are at highest risk of dying of COVID-19. And that is the reason why they targeted people that were over 80 years of age and those people in care homes, because they were the ones who had a greater chance of dying. What they also identified was that we needed to protect those people that are working within the health and social care system, because if we don't protect them and they become poorly, then where does everyone else go? Again, if you think about in my own practice, we've got 13,000 patients, we've got 11 doctors and nurses, and we've got our practice staff who are keeping lights on in the surgery. And that's why the Joint Committee for Vaccinations and Immunisation decided that this was the primary group that we needed to get the vaccinations to. The second group that we move beyond are those that have had increased risk of hospitalisation in the way that Salman has described, and those at an increased risk of exposure, and to maintain the resilience of essential public services, not just health and social care, but the police, ambulance, the fire brigade, and so on, the council and others. So these are the two groups that the Joint Committee for Vaccination and Immunisations have identified as people that need the vaccination, as we slowly start to roll it out beyond that. Next, you need to be aware of, and I'm going to put there the known benefits rather than the unknowns. We'll come back to the unknowns in a minute, and the risks that people might have of contracting, and the risks of COVID-19 vaccines and what might happen. Because ultimately, it is going to be a decision that you are going to be making once the offer has been made to you to have a vaccine. It doesn't matter how much money you have in your bank account, you cannot buy this vaccine. This is not about millionaires going out there and being these things. This is not something that you can buy off the shelf. The government is controlling the vaccine, and only those who are considered high risk are the ones who are going to be offered it. So when you are offered that vaccine, you've got a choice to make at that point there. Do you take it or not? The choice you can make now is to start to think about, if that opportunity arose, are you going to take it or are you not going to take it? And the reason I say that is because you have to consent for the vaccine. Nobody is going to force you to take that vaccine, but I've put in there brackets, unless you are unable to provide consent. And that doesn't mean that somebody else is just going to go around giving the vaccines out. But there are groups of people, for instance, those who've got dementia or those with severe mental illness who cannot consent for themselves, but are considered at high risk. And in a situation like that, a best interest meeting is called and determined what should happen. And I, as a GP, have been involved in that process, but as much as possible, it would be much better if you, at this moment in time, if you are able to give consent, tell your family how you feel about these things. Because if you're then become incapacitated and are unable to do so, then how is your choice going to be enacted? And it's important to put in things like advanced care plans, if you haven't done so already, so that your choice is not just known to you, it's not just written down in a document, but your family know about it so that they can champion it for you as well. But the important thing is that consent must be acquired for the vast majority of people who need the vaccine. You also need to be registered with a GP surgery. It sounds a bit simple there, but believe it or not, if you're not registered with a GP practice, you can't have the vaccine. So anyone out there who hasn't registered with a vaccine, they need to do this. And you don't need a driving license, you don't need a passport, you don't need a national insurance number, you don't need documentation like that in order to register. So if you're a refugee or an asylum seeker, you still are entitled to healthcare on the NHS. The NHS is for the people, period. And I'm a big champion for that. So please, please, please register with a GP practice if you've not done so. Otherwise, you won't even have the choice to be able to get the vaccine. And then if you're still unsure about whether it's okay for you or not, then talk to your GP or your nurse whom you trust. Of course, you can go out there and read whatever you want to read. Anyone can publish whatever they want to publish on Google and whatnot. But your GP and your nurse, whatever decision you make, whether you choose to take the vaccine or not, whether you get COVID-19 or not, you will be going to your GP or nurse for help anyway afterwards. So why not approach them early? Find out what your own GP surgery is saying, find out what your own doctor or nurse is saying, because they're going to support you through that, whichever decision you decide to make. And remember that the vaccine doesn't stop you completely from getting the virus. Even the best vaccines are about 95% effective. So that doesn't mean that once you've had the vaccine, it's a free-for-all and you can do as you please. You still need to protect yourself by making sure that you're washing your hands, you're wearing the face mask, and you are socially distancing yourself. And that needs to continue whether you've had the vaccine or not. And finally, yes, there are many unknowns, but believe you me, as a GP, I know about the harm that the virus is causing right now, right here, right amongst people that we know. And we've seen it time and time again. Those are real figures. Whether we can argue about how the data is being collected and all the rest of it, but I can tell you as a GP who's dealt with patients who've ended up going to the hospital, who've ended up being admitted onto intensive care units and coming out or dying, that's real. That's not make-believe stuff. And if anyone challenges me on that, I'm happy to be challenged on it. And I'm happy to be able to say that right now there are people dying or being affected by COVID that I'm dealing with. That's the stuff that we know about. And what we need to think about is what are we doing about trying to prevent that from happening, the things that we know about. So what about the Pfizer-BioNTech vaccine? It is suitable for vegans. There are no animal or egg products. It's not got any pork in it or anything like that. And as we just heard just now from Dr. Brother Wajid, the Meem have turned around and said that it is safe for Muslims to use this, but not just Muslims, because there are many other people as well besides Muslims who have an interest in this. Jewish people, Brahmins who don't eat meat, and many others, people who are vegan. It is safe for you to use. Many patients have allergies. I've been asked about, what about if you're allergic to penicillin? Is it safe for me to? Yes, it is safe for you to use. The contraindications, those who cannot have the vaccine currently, are those under 16 years of age. Tests are being conducted at this moment in time, so we're not going to be looking at what's happening to adults and trying to work out what children are. Children are currently going through trials to see the safety profile, but at this moment in time, because the data that was submitted did not include people under 16, if you're under 16, you cannot have the vaccine currently, unless you're in one of those trials. If you are trying to conceive, if you are pregnant, or you are breastfeeding, then again, it's contraindicated. You cannot have the vaccine. And that's because it hasn't been tested in those groups of people, and we don't know what the safety profile is for the unborn baby or the newborn baby. And finally, those who've had a very severe anaphylactic reaction. And when I'm talking about a very severe anaphylactic reaction, I'm talking about a patient who's collapsed as a consequence of having an allergic reaction to something. And they probably need to be resuscitated, or at the very least rushed into hospital and possibly needed adrenaline in order to bring their pulse and blood pressure back up again. That's the kind of person for whom it's contraindicated. Somebody who's had a slight rash as a consequence of taking a medicine or a food is not a reason not to have the vaccine. You should also, once you've had the vaccine, you should not get pregnant for at least 2 months after you've received it. That's another fact that's really important for us to understand, that it's not just about before the vaccine, but for 2 months afterwards, you should not get pregnant. If you do find out you're pregnant, it's not thought to cause harm, but you shouldn't try to get pregnant after you've had the vaccine for 2 months. And in terms of the known side effects, well, the majority of people don't get anything at all. But if you are, you're likely to get a sore arm where the needle went in, a feeling of tiredness, headaches, feeling achy, possibly a snuffy nose, and that usually settles down within a couple of days or so. Yes, we know about the 2 cases of anaphylaxis early on when the vaccine was given, but in both cases, they were people who'd suffered anaphylaxis before. Both people had EpiPens with them, they had adrenaline injections with them. Both of them were resuscitated, and as far as we're aware, they're well now. So really the side effects are minimal for the vast majority of people. Somebody asked, which of us actually had the vaccine? That's on the panel. Well, here you are, here's my picture. This is me having my first vaccine. I had it 10 days ago. In my case, I hardly felt the needle. I had no side effects whatsoever. There was no mark on my arm, there was no pain, there was no aching muscles or runny nose, and you can see I'm smiling there as I've got the injection. So there you are, for anyone who wants to know. Not only am I advocating that you should have the vaccine based on my own knowledge, but I've taken it myself. And that's despite not having everything, not knowing everything about the vaccine, knowing that there's still much we don't know about, knowing the fact that I don't know how long the vaccine will last for. But what I do know is I want to minimize the risks to myself, for my family, and also for those I serve, my patients and staff. And for that reason, when I was offered the opportunity to take the vaccine, I took it. It's a personal decision, and I completely appreciate and recognize the autonomy that you have, and you need to decide whether you have it or not. But in terms of for myself, I made the decision that it was right for me. And finally, on a more happier note, there's a great little game here. If you go on this website, coronabgame.co.uk, it's an award-winning game which is helping people to understand and break some of the myths on the vaccine itself. There's a series of questions it asks. So this one, for instance, the side effects of the COVID-19 vaccine are really bad, true or false. And when you click on it, it then tells you whether you've got it right or wrong. It's a lot of fun. I encourage you all to go on this game and play it. It's a free game to use. You can use it on your smartphones or on a website, on a laptop or a computer, and it helps you to start to understand what the vaccine's about, what it's trying to do, and what we're hoping to achieve from it. And finally, here's the information that I'm providing for my patients in my practice. On the left, you can see there the tiny URL HTMC coronavirus, which is all about COVID-19 and the symptoms, including the talk that I gave back in March on what coronavirus was all about. And the one on the right, which is all about the vaccination and what we are doing for our patients to support them through their care needs. Thank you very much.
Oh, thank you very much, Dr. Anand. You've given me a very good insight from the GP perspective and your honest opinion, and also you've been vaccinated yourself. I'm in pipeline, so I've not received any okay yet from my trust, so I'm in a waiting list. So hopefully when will be offered, inshallah, I will be going for vaccine as well. Now we are already slightly over time than we expected, but certainly the nature of this talk was that we want to give just information about the vaccine, and we leave the choice to the people and their understanding. And as rightly Dr. Aminan has mentioned, few links to read yourself to find this more information about it. The whole idea is to give the as possible accurate information about the vaccine, its a risk, and why we are doing it. So now we will ask because obviously when we circulated our Zoom link, we asked the people to send their questions. So I have a list of questions which they have sent. I think majority of them not put their name on it, but I will just throw to the panel. And some of the questions we will probably not repeating it, like for example, that is it contain any human or animal products? I think it's been very adequately explained that there is no animal or human product or any of these things in this vaccine. Now, I will ask the first questions is obviously relevant, and I think maybe Dr. Amahanan can better answer this one. The question is, once I have been vaccinated against coronavirus, am I exempt from lockdown restrictions?
No, you're not, because of the reason I explained, that the coronavirus doesn't stop you from getting COVID-19. You're still at risk of getting it, even so. And so you must continue to try and protect yourself. And remember that lockdown has been the most effective way of reducing the spread of COVID-19. We've seen it time and time again, how it's reduced the numbers of COVID-19 simply by stopping people from meeting each other.
And the second question is to the panel, if a person is vaccinated against COVID-19, will they be able to spread the virus to other people?
I can answer this question.
Yes.
So up till now, the data suggests that if you get vaccination, that definitely you can get the infection. It means you get the virus, but you will not be affected with the virus. But still you can infect the people. So this is still the question in place, which is being investigating. So yes, at this time, we can say that if you get the virus, you can infect the people. So you need to continue with all the measures like mask, safe distancing, and all those like social distancing and other things. Yes.
Salman, can I just sort of add to that? So I think what we are saying here is that if you do get the vaccine and you then get the infection, then you can convey to others, because the vaccine is not going to give you the infection. So let me just so clarify that two different aspects of that on there.
Yeah. Okay. So the other question is relevant to the group of the people who have allergies. Like one is that fruit allergy carries EpiPen. And other question was relevant to that is that what if the patient have asthma, eczema, and hay fever? Like if they have atopy, would they be able to have vaccine? Any Dr.
Yeah,
Ahmed?
I mean, it's very clearly mentioned in the official Green Book chapter, which is online, which is the official correspondence from the government, is that people with any sort of allergies, they should not be offered the vaccine. Now, whether there are some gray areas where you class them as people with allergies or not, I think the default should be towards don't offer it to them. Now, if there is a person you definitely want to be vaccinated, you can speak to the local specialist like immunologist to sort them out. But the official answer is they should not get it.
Salman, can you look on the other question? I think some other questions coming into the panel as well. You unmute yourself.
I can quickly raise it because there are quite a lot of people, and I think Dr. Raza can give the answer properly. That you know the recent UK new strain of virus keep coming, and there is a question: is this vaccine can be okay for this new strain virus?
Yeah, I mean the question about whether the new strain is covered by the vaccine, I don't have any reason to believe that it will not. The vaccine strain is a whole discussion in itself, but just as a short summary, I would say we don't have to worry about lack of coverage with the current vaccines unless there is some more data which emerges contrary to that.
My understanding is that the protein that is helping to stimulate the immune system is the key. And as long as that part doesn't mutate, it will continue to remain effective. Is my understanding, Dr. Naqvi, is that?
Yeah, that's right. And again, there are so many different aspects. There are the genotypic aspects, the phenotypic, where it translates into the protein which you wanted to make. And the receptor binding domain is one part of the virus where it all is the immunogenic or the main immunogenic part of the virus. So what I would say is that these are theoretical questions with no solid data to back up the claims that it may or may not. So these are all things circulating in academics' heads at the moment.
The other question is that obviously, I think it's maybe a valid question that will I be forced to have this vaccination? I think Dr. Ramanan can give a better answer.
No, I explained that you have to give consent for this, which is why whilst you're waiting, it's important for people to decide for themselves what they want, tell their loved ones. And if you choose not to have that, that's okay. That's, you know, as long as you make an informed decision based on the knowledge that you've got, and hopefully you've used trustworthy sources, then that's great. What you don't ever want to do is end up with the condition, end up in hospital or on an intensive care unit, and then turn around and say, I wish. And sadly, after the MMR debacle that we had, lots and lots of people ended up saying, I wish I hadn't listened. Again, you know, I have seen both sides of the coin. I've got patients who don't want the vaccine, and I've got others who do. I've seen patients who've been affected by it and those that haven't. The important thing is make a decision and think about it now. Use the information that we're providing for you so that you are ready for it for when the time comes, but nobody can force it. The only scenario where that's not true is, as I've indicated, those people that are demented, who are unable to provide consent themselves. It is a grey area. The government has provided guidance because we are going out to care homes to give the vaccines to our very, very vulnerable people. And there's a balance there about the risks of COVID, where those are the ones who are dying in care homes, and the potential benefits of you know, not getting side effects, if you like.
There is I can raise a question, Dr. Tariq. I think it's go for Dr. Amir Hannan, that there is a video clips on WhatsApp claiming the GPs are making 50k pounds a week by issuing the vaccine. What's your claim on this? What do you think?
GPs are not making 50k, and I definitely don't. I'm not making money out of this. There is a huge cost to actually delivering the vaccine itself. Doctors, nurses are taking time out to go and deliver these vaccines. There's a cost in terms of storing the vaccine, delivering it, and actually rolling it out. There's been a huge education piece that we've all had to do. You can't just go and give a vaccine. You have to spend hours and hours learning about it. The consent process, the process of checking that you've had the vaccine, adding it into the records, all that is cost. And by the way, that is not just the doctor doing it. We've got amazing practice managers, reception staff, healthcare assistants. There's a whole army of people that you might not be aware of that are working behind the scenes. And I think most people, most of my colleagues, and again, I say this as chair of the Association of Greater Manchester LMCs, feel that GP practices are probably going to make a loss overall. It doesn't actually cover the cost of it, but we're doing it because it's what we do. We want to keep our patients safe. So anybody out there saying we're making a whole load of money out of it, I challenge them on that as well. Thank you.
The other question is that I think there are quite a few of similar nature questions that obviously this vaccine is approved, but the other vaccine with the AstraZeneca is on the horizon. And I think probably within a week, I think that will be approved. So the question is that which one you should choose for the vaccine. I don't know whether they will have a choice to have between these two vaccines, but the question really is to, if I'm given a choice, which one I'm going to choose it. I think Dr. Lakwi maybe put some light on it.
Sorry, Tariq, I missed that.
At the moment we have the Pfizer vaccine which is approved, but the AstraZeneca, the other one vaccine, will be soon approved. That works in a different way. So the question from the audience is that which one you should choose between two.
Well, I mean, it's yeah, I mean, it's a difficult question. I do not know what the data will show, and I do not know what the logistics will be like. So it's a combination of, and the cost obviously comes in the equation. It's a question about the efficacy, the data, what it shows, the safety profile, etc. So I think it's a bit premature to say which one is better over the other?
So from a GP perspective, the best vaccine is the one that's offered to you that you actually take. And so the healthcare professionals that are responsible for delivering the vaccine within communities. And again, to give you some idea of the machinery, that will include public health specialists, that will include CCG colleagues, it'll include NHS England, it'll include the microbiologists and virologists like Dr. Naqvi, and others are coming together to work out what's the best vaccination or vaccine to be given. The Pfizer one was obviously the first one that's, and at the moment currently is the only one that is got licensed to be delivered. GPs around the country, even this weekend, I'm on various networks, have been calling out to say, we really want to give the AstraZeneca vaccine. And the reason for doing that is because you don't have to keep it at -70 degrees centigrade, so that GP practices who are very, very well versed in giving flu vaccinations, which they keep in their fridges, would be able to apply the same principles to give the AstraZeneca vaccine right in their own GP surgeries. So GPs right across the country are calling out to say, can we please give the AstraZeneca vaccine, because we know how to do that. In case anyone's wondering why it hasn't happened, the reason it's not happened yet is not because of NHS England. It's not because somebody's preventing it. It's because the regulatory authorities, the MHRA, are the body who have to look at the evidences that are provided, and they have to agree to licensing it before it can be deployed. So at this moment in time, it's with the MHRA. They are looking at it, and as you say, once they've licensed it, there will be the opportunity for a second type of vaccine. My own feeling is that we need to trust the experts who are offering the vaccine. We're working out the benefits of giving something that's -70 and all the difficulties that has with something that is more readily givable through your own GP surgery.
The other question come in that if you already have a COVID-19 infection, would you still benefit to have the vaccine?
I think Dr. Naqvi can be able to give this.
So if you've already had the COVID, then is there any benefit? I, as a virologist, what I would say is that if you've already had the infection, then you're protected from natural immunity. Now, of course, things will evolve, and you may find out, like flu, that the vaccination is required on a more regular basis because the immunity doesn't last. So at this point in time, I think they're not asking you not to get the
antibodies.
The vaccine. Yeah, I mean, the testing the antibodies and then vaccinating is not what is happening. I think somebody who's in the middle of a COVID acute infection, certainly they ask you not to be vaccinated. And I think people who've definitely got a proven history of COVID more than 90 days ago, I think they may benefit from this vaccine because it will act as a booster. But that's the sort of a gray area where you have to go back and see what the policy develops as.
I think the WHO recommendation is that whether you had a COVID infection or not, anyone can get the COVID vaccine. As the other, like we have measles in the past, but we're still getting the vaccines, and it doesn't cause any problems or any side effects. So you can, and you don't need to get antibody tested before it.
I think there's a really important point to make about a lot of these questions, because we see a lot of the comments that are there, and they're saying that, how do you know X or how do you know Y? And it's something that's useful for for people to remember, is that one of the really dangerous things that are happening is attempts by certain individuals to try and break the trust between the public and their healthcare professionals. We know that some people mistrust government because governments do good and bad things. We know that people mistrust pharmaceutical industry because they have a checkered history. But your healthcare professionals are the ones you trust with your life. When you have a heart attack, you're not going to go to that random guy on WhatsApp, are you? Because he doesn't know what to do. When you have your children need surgery, you trust those same doctors to put an anesthetic on you and to operate. So those same people you trust when you have a heart attack or when your children need surgery, now suddenly they are traitors to themselves, their own bodies, their own families, their own community, to Islam, to medicine, to everyone, it doesn't make sense. And this is one of the key points, you know, like every issue you'll find something. You'll say, what about X? What about mutation? What about cold storage? What about, and you can do what about forever, but you would not do that if it was your own child or your own parent on the operating table. You would say, Dr. Saab, please help. You will make dua to Allah and you'll say, Doctor, help. Now, we're not saying trust us blindly. No one is saying that. We're saying ask the question, but at the end of the day, be very careful about those people, like the £50,000 a week for the GP. That is a deliberate lie that is being spread by certain people. They're trying to make you think that we're in it for the money. That's the deliberate lie. They know this. They keep spreading these rumors. The ones that say that, oh, there are other people, there are other specialists out there who give the alternative view. Well, let's be honest. The ones that were mentioned in some of these videos going around are people who have been, who unfortunately do not have, they're not even medical doctors, many of them, and many of them unfortunately have not got the, have been taken away from the medical register for saying mistruths. So it's something that we need to say, go speak to the doctor you trust. Your GP, he wants to keep you alive. If he gets paid for anything, he gets paid to keep you alive, by the way. You know, he gets paid per person. He wants you to live. So go to your GP, go to your doctor, and they will help.
Two other questions, I think they come through the email now. One is that, does it change your DNA? Because they are giving the example of genetic modified food and perceive that it may not be good. So they're thinking, is this vaccine, I think we have already answered it, but again, it's come with this context that is it going to alter the DNA?
Well, I mean, we are not giving them DNA, are we? We are giving them messenger RNA, which is completely different. So the messenger RNA quickly degrades once it's done its role, and there is no risk of it going into the nucleus and then damaging the DNA and then taking over the humans and creating different shapes and forms. No risk.
Yeah, that's true. That's true. Salman, can you look on, is there any other questions coming from the panel? I think we are quite a bit of over time. I'm looking for the watch as well. So, but I want to keep all the people having the questions answered.
Yeah. I think that because of a lot of questions are coming, if our panelists, if they have time, that they can answer on Facebook, reply it via chat, that will be helpful in the future, because we can't able to ask all the questions. A very quick question, Dr. Wajid, is that this consensus statement of the BEMA, which comes out, definitely it's Pfizer vaccine came in. Does it imply the basics for the future vaccines which are coming, or definitely you will think about when the AstraZeneca vaccine comes, then you give them an assessment?
That's exactly what we would do. We will, when the data, we have a team there already with just looking at the data as the data comes out, and when the full data is there, we will go through the same process. We're not giving rubber stamps. I think a lot of people, you know, these words, boot lickers and stuff go around, that these guys, I don't know whose boot we're supposed to be licking, you know, but we're not here to rubber stamp everything. We got to take this vaccine, by the way, guys, right? We're human beings like you. Have some mercy on the rest of us as well, and our parents. So when it comes out, if you can trust us, and we would look into it, and we will give you the recommendation. You make the decision, inshallah.
Last two questions before we finish. So one is that this is from the healthcare worker. I have a food allergy and carries EpiPen, and also diabetic, but I've been refused to have a vaccine. Any take on another similar scenario is that I am immunosuppressed on the immunosuppressed medication. Can I have a vaccine? So these two questions before we finish.
Yeah, I mean, two questions. If you talk to your GP, they will guide you in this, but the understanding is that the vaccine is no risks to people who are immunosuppressed.
Compromised, yes.
They may have reduced efficacy, that the immune system doesn't generate enough responses, but certainly it's safe to take it from that point of view. Regarding the allergy, I think this is more of a off licensing where they will have to speak to the local specialists. And now, for example, in Sheffield, what our immunologists do is they would bring these people to their clinic. They will give them the drug against which they are vaccine, and then they will watch out for symptoms. And if it does happen, they will be available then and then to sort it out. that's the only way. Or you can just wait for another one where it's been documented, another vaccine where it can be given to people with allergies.
Okay, thank you very much. I think I'm especially grateful for our speakers, Dr. Raza Naqvi, Dr. Amir Nan, Dr. Salman Rashid, and Dr. Wajid, who came on this panel and answered these questions and given the time. And also, I'm very grateful for all the participants who came in and given their questions sent through us email. And I think probably we will follow on, inshallah, and hopefully, I think once the conference build with more of the other vaccine coming and future things, we may consider another webinar of the similar nature to give, because the whole idea is to disseminate the accurate information and leave the people to make the decisions in an informed way where they have a right sort of information. So grateful for everybody, and I'll just
can I just add just one other thing that
yes, please.
I've got no conflicts of interest. I think each of the panel members should just say that we've got no conflicts of interest. We've not got any shares in any pharma companies or anything like that. I think that's really important.
Absolutely.
So I have no conflicts of interest.
Whatever I've said is in my professional capacity without having any conflict of interest.
Same here, no conflict of interest.
No conflict of interest.
I think we all were volunteers and we giving the time and other things. So certainly, I think it's a good point you have raised, but obviously sometimes even the obvious things you have to say that I don't have a conflict of interest, and it's a very good point you have raised. So thank you, everybody, and Allah Hafiz.
Allah Hafiz.
Allah Hafiz.
Hafiz.